All right, hey everyone. We're going to go ahead and get started. Thank you all for logging on. I see some UCH residents and Robert, Randy, and Nemi. Awesome. So we're sitting in a room with some VA residents who are going to be participating as well, but feel free to chime in the chat or just talk out loud if you guys have thoughts. So today, conference is going to be called VA Overload. These are going to be two patients who I had on my team here at the VA in the last week or so, who both sort of exemplify different spectrums of the same illness, which will not be super subtle. So with that, the map you're looking at here is a map of a portion of the Front Range. I circled Aurora, and then there's a marker pointing to Drake, Colorado. So it's a very, very small town. One of our patients is from Drake, the other's from Aurora. So people in the room, which one would you guys rather start with?
Drake.
All right, we're going Drake. So Luke has decided to do Drake, Colorado first. So Drake, Colorado is HPI. You've got a 74-year-old man with BPH coming in with 1 month of worsening shortness of breath, leg swelling, and scrotal swelling. 1 month prior to presentation, he had increased dyspnea with exertion, which he says he was chopping wood and working on his cabin. He has swelling of both legs and swelling of his scrotum. He also has gained weight. He's now 183 pounds. He was previously 145 pounds a few months ago. No chest pain. He lives remotely in the mountains without power, a phone, or a mailbox. And he says he's never had any prior issues. He has had no prior illnesses as far as he can remember. This should be not the most difficult differential, but what are you guys thinking? Great, heart failure. And Natalie, why is this setting off the alarm bells? This person has heart failure? Or sorry, Kristen. Or Natalie. Who talked? It was Natalie. Great, it was Natalie.
Shortness of breath, kind of the slow accumulation.
Awesome. Yeah, so really great. So Natalie hit the nail on the head. He has sort of like the picture perfect story for some sort of heart failure or volume overload syndrome based on the highlighted things which she said. Okay. I'll tell you, this gentleman's vitals are basically normal, and his exam, he's got 2 to 3 plus edema of his legs and of his scrotum, and he's got some kind of crackles bilaterally, but so we'll go ahead and say that this gentleman, as we start to think about him, is in that warm category. Okay, you get a chest X-ray in the ED, and first we're going to look at this guy's prior chest X-ray. So this is a chest X-ray 1 month prior to coming into the hospital. He got this because he was sort of having some of these symptoms, but not all of them. So take about 30 seconds, and I want you guys to give me your, I'll ask one of the interns to give me their focused read of this PA and lateral. Luke, you are sitting closest to me, unfortunately. So what do you think?
So I think his lung volumes look quite large. So I'm wondering if he has some degree of COPD. Then I don't really see tight costophenic angles here side. So I'm wondering if he has some bilateral effusions. And then maybe it's like there's a little bit of vascular congestion.
Awesome. That was a fantastic read. I completely agree. I've got no additional points. Luke hit the nail on the head. This lateral X-ray is just about the perfect example of what a barrel chest looks like, right? It looks like this man is like hiding his internal organs inside a barrel. And we don't often see a aorta this crisp, but that is his thoracic aorta sort of extending backwards right there. So Luke does a fantastic read there. And so now let's give the acute X-ray. So this is the X-ray that he gets in our ED. And it looks like this. So I just asked Luke a question, but Luke, I'm going to defer to you one more time. Big differences between this X-ray and the one you just looked at.
Yeah, I'd say like a worsening reticular infiltrate concern for pulmonary.
Great. So worse infiltrates, and your number one concern is pulmonary edema. Fantastic. That's awesome. Okay. So the teaching point on this X-ray, and we're going to make it a little bit smaller here, is that there is, we don't often talk about this, but you can actually sort of correlate chest X-ray findings in heart failure to your pulmonary capillary wedge pressure. And so if you're pretending that there's this like barometer here next to this person, they did a study back in the 70s, like Forrester and like the famous cardiology group out in LA, where they Cathed people who were in acute heart failure exacerbations. And they basically tried to see like what on the X-ray correlates to what pressure, wedge pressure specifically. So for the room, what's the first abnormality that we see on a chest X-ray? Like what happens at 18? I like it. Luke guessed hilar prominence. He's close. So I'll tell you the hilar prominence comes in here at 18 to 22. So number one is actually cephalization. So where is their cephalization on this gentleman's X-ray? So if you scroll in right here, cephalization is essentially prominence of the vasculature in the upper lung zones. And so if you can trace this gentleman's vasculature upwards like this, that's cephalization. So having cephalization in this study tells you that their pulmonary capillary wedge pressure is probably at least 18. Okay, so we then said that if you keep getting higher, we said there's hilar prominence. What else do we start to see? So I'll tell you, we start to see interstitial stuff. We also start to see curly B lines. And then we see something called peribronchial cuffing. And then if we keep going even higher, that 22 to 25 range, this is when it starts to look like alveolar opacities. So you have so much fluid that it leaks out into your alveoli. And so does this gentleman have curly B lines on his X-ray? Can anyone identify whether he has them or not? He definitely has interstitial stuff like Luke pointed out. If you had a computer in front of you, you could probably see that there is some stuff kind of out here towards the periphery a little bit, and there's some sort of stuff out here. You're looking for those horizontal lines that extend all the way out to the periphery. It's not the most classic example, but if you had a better computer, take my word for it. Okay, so that's how we can correlate our pulmonary capillary wedge pressure to an X-ray. Me and Eric talked about this the other day. This is not the most like hard and fast rule, but just an interesting thing when some extra info we can get from our X-rays. All right.
Go back to the lateral.
Yes.
Yeah, I think the other thing worth mentioning on the lateral is that it's aorta. It's really easy to see. Danny pointed that out. I think that there could be emphysema that makes it easier to see if there's a lot of air in the lungs. But I also worry about like a very calcified aorta, and so already I'm trying to think of, is this person have ischemic disease that's driving this process?
Perfect. So not to belabor this too much, how do we work up heart failure or possible heart failure? Sorry, say it louder. Echo, great. There we go. So we have got all the echo images. So this is this person's first echo image. So for the interns in the room, what image are we about to press play on? What view? Great. So this is going to be your peristernal long axis view. So right, we go through our echo images in the same order every single time. So we start with peristernal long, and now we're going to play this and run it through a few times. And right, none of us are cardiologists yet, but we should be able to make some sort of like, rough estimates based on what we see. So I'm going to loop it. And then guys, just call out abnormalities that you see. Okay, Luke says there is a large left atrium. He is correct. Great, so Luke is like informally referring to like the EPSS or the endpoint septal separation, which is how far that mitral valve is moving. And as Luke astutely points out, it's not going where it should, or it's not going as far as it should. And so Luke, what does that tell you? Yeah, great, so this person has a low EF. And so there are pretty good studies that show that even non-cardiologists can make sort of grossly abnormal versus grossly normal calls on echoes. And so as a room, would you guys say this is grossly normal or grossly abnormal? Perfect. This is a grossly abnormal echo. Eric, any additional thoughts on this?
No.
All right. So you're in the peristernal long axis. What view do you guys want to obtain next? Perfect. Peristernal short. And Dom, how do you obtain your peristernal short view?
So your point is usually what, the 2 o'clock position for this person of palms, and then 20 o'clock, 10 o'clock position. I might got that mixed up.
Yes, partly, right? So you have it in the peristernal long and you tilt it, right? So you just basically change your rotation.
Same orientation.
Same orientation, twist it. And so if you imagine you're going right shoulder for peristernal long, and you're going to basically aim to the left shoulder for your peristernal short. So here's a peristernal short. What valve are we looking at right in the middle here? Great. So this is the mitral valve. That's that classic like fish mouth appearance of the mitral valve. And so, Eric, what are your thoughts on this peristernal short?
Yeah, so the RV is huge in this view. I thought it looked a little big on the peristernal long, but it still looked about half the size of the LV. Here you can see the RV is like almost double the size of the LV, so that's concerning to me. And then you're really looking for like the rotation of the wall, which is a normal measure of contractility. And I'm just seeing like the septum is like not moving here.
Yeah, perfect. So if I outline the septum, you can see that there's like very little movement in and out of those 2 red lines that I made. Great. Okay, what's the next view we want to get after our peristernal short? Great. Apical forechamber, moving our way down. How do we obtain our apical forechamber?
Mid-axillary, usually taking up towards your right shoulder, like 5 or 6 ribs.
Awesome. So yeah, so Dom was saying basically mid-axillary or right under the nipple in some people, and you want your dot on the probe basically going toward 3 o'clock, so directly out from the patient, but it depends on the person's anatomy. And this is this gentleman's apical forechamber. So again, just call out what abnormalities do you guys see? Or is this normal?
Both atrium.
Awesome. So both atria are enlarged. So his left atrium and his right atrium are both huge. His LV is large. And then if you guys are going to make an assumption about his EF here, let's just throw out some numbers. Awesome. I like it. So you guys were actually pretty close, which speaks to like the studies, but he's about 15%. So he was in that 15 to 20% range. Eric, any additional thoughts?
Yeah, the windows here are pretty incredible. So you get a really nice view of the large papillary muscles there right below the mitral valve. And when I looked at this person's echo a couple days ago, you can see actually the chordae really well, which I'm not seeing as clearly in the projected view, but really, really good windows here.
Awesome. And then what's our very last view we're going to obtain here? Subxiphoid, great. And so subxiphoid, right, we put it basically under the xiphoid. The name is not misleading. And this is the view that we get. So you can see the liver at the top, and then you can see the cardiac chambers below. And so, right, we're looking at the right atrium here, the RV is there, LV, left atrium. So another question, right, this person has fluid where they shouldn't have fluid. Do they have a pericardial effusion or a pleural effusion? Plural. And Bill, why'd you say plural?
You can see it through the lines. Through the fluid as well, which is like it's the lung space. It's also not like perfectly certain differential, so we could sometimes people do have an isolated pericardial effusion, so there's no massive.
Great. Yeah, Bill's right on. So you can see that there's some B lines over there on the left side of the image. And then if you're looking at his fluid stuff over here, this right here is his pericardium, that line right there. And so everything below that line is going to be pleural. And so that's going to be pleural fluid. And then there's a very, very small physiologic pericardial effusion above it. All right, so this gentleman has rip-roaring heart failure with an EF of 15%. So what I want you guys to do is take about 30 seconds to a minute at your table and create sort of a process or a schema for working up new cardiomyopathy. So what questions do you want to ask? What information do you want to know? All right, cool. Some good discussion. So Mandy and Yuna, yeah, that's Yuna. Yuna, what were you talking about? What's kind of your thought process whenever you have a new heart failure patient that you pick up?
So we kind of think down we kind of go down levels of a tree. So you have ischemic, non-ischemic. Ischemic's pretty common for new heart failure. So you might want to do a stress test or some Cath, work that up. And so then that's kind of on this more straightforward area. Then you go down the non-ischemic pathway, and then there's all sorts of branching, rheumatological, it could be malignant or hematological, term infectious or medication related, and then you go down a rabbit hole with your many labs that you can sound ANA, SPAPs, EPAPs, all the infectious stuff PSA, HIV. Take a look at their med list to see if they're on anything that has a potential side effect or you might not be.
Great, I like that. I wouldn't do that justice by summarizing it. So I'll just say that what Yunan sort of expertly hit on is that the non-infectious part, right, is basically history based, right? You're taking a really good history and you're seeing what can I order and what should I send off as opposed to a shotgun approach, which Eric will advocate for. So Yunan, you mentioned meds, infections, drugs. You can also get that genetic family history, right? That's when we ask if you a family history of heart failure or things like that. What else do you want to ask about? Travel. So for instance, if they've recently come from South America or they're born in South America, is Chagas disease more prominent? And then once you get through this sort of whole list of what meds are you on, what infections could you have had, drugs do you take, genetic history, travel, that's when you get into your serologic workup it's sort of, low cost, high reward. And so that's HIV, your ferritin or your iron workup, and then a TSH. Eric, any additional thoughts on approaching the non-ischemic portion of
yeah,
the
there's so many causes, and so it's really all just history in terms of what you're really going to focus on. I think the labs that are worth probably sending in everyone is probably HIV, ferritin, TSH, and I add a urine drug screen for things like cocaine use. And then alcohol is another common one in our patient population. Again, that's kind of all history, but yeah, I think the things there when you start making out a list and doing shotgun approach, and even considering in endomyocardial biopsy, is when patients aren't responding to the therapies that we're giving them, and their heart failure persists despite really good therapy. That's kind of when it's indicated to sit back and think, do we need to start looking for some of these rare things.
Perfect. All right. So I'll tell you, this guy has some labs sent off, and he gets a Cath. So his Cath shows a non-ischemic disease, which I think all of us were probably not expecting when we first saw this man. And I'll tell you, he has a non-ischemic process, and this is his right heart cath numbers. So what I want you guys to do is take about a minute at your table and tell me whether these are normal, abnormal, and what does it mean? All right, let's come back. Some good discussion here. I'm coming back, so I'm gonna interrupt Dom because Dom was talking about something useful. But before we do that, Dr. Lublin just brought up that we have the kissing bug, the bug that causes Chagas disease in Colorado, but apparently it's a different subspecies, which is not as easily transmit Chagas. So we have the vector, but we don't have, how do we say it? I guess we sort of have a vector. We have a version of the vector, but that's why we don't get Chagas here. So now we all learned a little something about the kissing bug. It's a good fact. I had no idea about that till Dr. Lublin just told us. Okay, back to what Dom was saying. Dom, what are our normal pressures?
So for right atrium, 0 to 5. Right ventricle is like 20, I'll say 25 to 10. Your PA is usually like 15 to 5, 10. And then your pulmonary wedge pressure is like between 2 to 15 or something like that.
I like that. And then how about what's our normal LV pressure?
Oh, it's not that.
Right, so that's like our actual blood pressure. So the way that I was taught this as a medical student is nickel, dime, quarter, $1.25 for inflation. Is like a easier way that I've like remembered this, and then you sort of have a little bit of variance around both of those. So based on this, what pressures does this person have that are elevated? All of them, great. So his wedge pressure is elevated, his PA pressure is elevated, his RV is elevated. Perfect. And then how about his output and his index? Is that normal, abnormal? Low. What is our normal cardiac output? Great. So like 5 is probably roughly normal. So this is definitely low. And then our normal cardiac index? Sorry. There was like 45 Voceras just went off at once. Eric, what's our normal cardiac index?
I think the lower limit of normal is 2.2.
Great. So perfect. So cardiac index is your cardiac output adjusted for your body surface area. And so this gentleman has a low output and a low index. So this is objective evidence, right, that he has heart failure with elevated pulmonary capillary wedge pressure and an elevated PA pressure as well. Okay. So now to the management part. How do you guys want to treat this gentleman? Just as a reminder, right, he is warm and we'll say he's well perfused right now. Diuresis, perfect. Awesome. And what would you just because we often don't get people who have never had Lasix before, what would your starting dose of Lasix for this person be? I like it. So diuresis, and you're going to say like 40 of IV Lasix right off the bat. I think that's a pretty good starting dose. The House of God advocates that, you take their age plus BUN as their Lasix dose, but that's almost assuredly going to overestimate it for people who have never been on Lasix before. And so a good starting dose for most people is 20 to 40, depending on how relatively sick or volume overloaded they are. Okay, What other medicines, if we're going to make our hashtag list, does this person need? Beta blocker, great. Dom, what's his indication for a beta blocker?
Yes, did we say, I missed the beginning part.
Oh, sorry, no, you're correct. He does need a beta blocker. What's his indication for it? Don't overthink it.
He's an art.
Yeah, great, he's an heart failure. So that's his indication. And so, right, metoprolol, succinate, bisoprolol, or carvedilol are our beta blockers. What else does he need, right? His EF is 15%. Okay, so he needs an ARA, right, because his EF is less than 35. Perfect. What else? Great, so he's going to go down this like ACE inhibitor, ARB pathway. Does this gentleman qualify for an ARNI?
Yes.
Perfect. Eric, tell us a little more. What is that study that told us that we should give this person an ARNI?
Yes, this was studied in the Paradigm HF trial a few years back now. And that compared an ARNI to enalapril and found that there was a 20% reduction in cardiovascular death or heart failure hospitalization, and it, I think, was pretty close to equal in both of those outcomes. So that was probably the biggest thing in heart failure in quite a long time. So that was great to have that in our back pocket. The patients that had class 1 or 2 heart failure did better. There were very few patients in like class 4 heart failure. So, I think this patient was perfect. Like he's probably like, after a little bit of diuresis, will probably be class 1 to 2-ish. And then you talk about the Pioneer HF trial as well, which compared the same drugs, ARNI to enalapril, in hospitalized patients with acute decompensated heart failure. So this patient, not stable outpatients like Paradigm. The primary endpoint in Pioneer was NT-proBNP. So you're like, well, that's really weak outcome, right? But I think the point is that the safety, it wasn't set up as a safety RTC, but the safety endpoints showed there were no differences in adverse outcomes in the ARNI versus enalapril. So that was really important for us to know that we can safely start an ARNI in patients with acute decompensated heart failure.
Awesome. All right, great. And then just to complete this list, right, and I'll have another teaching point from Eric here in a second. We asked, should they have a device, right, which we're not going to talk about this noon conference. And then, right, we talk about, are they eventually going to be a transplant person? And so that's, yeah, you called my bluff there. At this point, we're going to start putting SGLT2s in the water, but this person, yes, would probably meet all the indications for an SGLT2 outside the hospital. And so, yes, so now we can all add SGLT2 on here before we start including it in our breakfast cereals. Okay. The really confusing thing is, and we struggled with this on our team, is when do you start the ARNI in the hospital? Like what dose does the person have to be on? What meds can they get beforehand? And I've had to look this up every single time. And so Eric at 11:40 this morning was like, there's an app, Danny. And I was like, oh, great. So if you open up this app right here, this is the Treat HF app by the American College of Cardiology. It is free on the App Store. And essentially all you do is you go to their therapy reference page. There's an evaluation page and a therapy reference page. And you can click on the medicine. So if you click on ARNI, it gives you essentially everything you would need to know about starting it in the hospital. So you can click initiation and you can see, de novo, right? You can just start it. Or if they're on an ACE or ARB, it tells you exactly what you need to do. So they need to be off the ACE for 36 hours, but there's no delay required if you're going to start them on an ARB. And so this is a really, really helpful app for non-cardiologists if you're trying to figure out what to do with someone's cardiology meds inpatient. And honestly, it's probably helpful for cardiology as well, because they give you all the studies, dosing, everything else. So just another shout out to Eric and his Treat HF American College of Cardiology app. All right. Great. So this gentleman was not started on an ARNI because we didn't know about the app, and we gave him his dose of his ARB that morning. And he was transferred back to Cheyenne for ongoing diuresis and further heart failure management, but was feeling better when he left. So just as a reminder, that was our first case. That was the case of the gentleman from Drake, Colorado. All right, so let's go to our second case here. This woman is from Aurora. This is a very long history, but I'll just tell you the notable parts are all in the chief complaint or chief concern. She says, I have sarcoidosis and I feel short of breath. So with that, then you get this really, really good history that Caitlin Bell took. And essentially she says that she woke up in the middle of the night to urinate and when walking to the bathroom felt dyspneic. She usually wears 2 liters, but had to increase it a little bit. She says she was in her usual state of health yesterday. She didn't have any difficulty or shortness of breath. But right now she just feels shortness of breath related to prior flares of pulmonary sarcoid. She has chronic orthopnea down here. She always sleeps with pillows and she has a 10-pound weight gain, which she says might be because she was trying to gain weight, but she wasn't sure. Okay, so let's take a look at her echo now. So here is her first echo image. So take some time here to look at this. And I want you guys to compare this to our last patient. That's what the importance of this one, and tell me what's different, the same. Great, so Dom says her LV is enormous, right? So this is her LV, so her LV wall is significantly more thickened than our last gentleman, okay? And then right, we're starting to sort of build our skills estimating EFs. If you guys were going to estimate an EF based on this person's echo, what would you guess? So you're saying this is worse than the last one?
No, actually, there's a bit more squeeze.
All right, so we've heard 40, we heard 30. I'll tell you this person's EF ends up being about 50%, but it was called abnormal. So it is decreased, but not substantially. So think about what it looked like compared to the last one. Okay, so what's our next view, just to hammer this learning point home? Great, parasternal short. So this is our parasternal short. So what does it compared to the last one? Does this look better, worse, different?
Better squeeze.
Awesome. So Dom's pointing out that there's better squeeze. And I think you can point out, right, if I draw a line where the septum starts, you can see that the septum moves down below that, right? So you're seeing more squeeze compared to the last image. Okay. What's our next image? 4-chamber, perfect. Great, so the atria are not as dilated as the last one. So right left atrium, right atrium, perfect. I'm not seeing a whole lot of her right heart, but it's there, I swear. Okay, right, and we said this EF is better. So this EF was roughly in the 50s, and you can tell that, right? If you're looking at the LV, right, you can see better squeeze. So finally, the cardiologist throws some Doppler across the RV, and get this. So her tricuspid valve is on the left side of the image where the Doppler is going across. And if anyone feels brave enough, what valvular abnormality are we looking at? Yeah, awesome. Now the tricuspid regurg. Why are we looking at tricuspid regurg? Sorry, say that one more time.
I mean, it's obviously going across the tricuspid, but it's leaving.
Yeah, that's correct. So let's just pause this here. So I said this in a prior conference, but one of the teaching points that a cardiology fellow gave me when I was a student was to think about the colors as a like BART, like the California Transit System. So blue is away, red is towards. And so if the color is red, it means it's going toward the probe, right, which is up here at the top of your screen. If the color is blue, it means the blood is going away from the probe. And so if you pause it in this image right here, you can see that there is a substantial amount of flow which is going away from the probe. And I think in cardiology, if you're going to quantify this, you can quantify it as to how far back it is in the chamber. And so you can see that it's essentially touching the back wall of the right atrium. Eric, any additional thoughts on this?
Yeah, so you can actually use that Doppler jet to estimate the pressure gradient between those two. So if you think about back to physiology, your Bernoulli equation, if you remember that one, you make a ton of assumptions, and then it simplifies to basically 4v squared as the formula used. So you can measure, you can use Doppler to say what's the velocity of that jet right at that moment, and you know that the difference between the RA and the RV has to be 4v squared. So do you have what the velocity was?
Oh, you're asking a lot of me. I don't have the velocities.
Yeah. So,
I wasn't prepared to spell Bernoulli either, so.
and then once you have that pressure, you can estimate what the PA pressure is, because by knowing what the RA pressure is. So echo is, everything is indirect in echo. We make a lot of indirect measurements. We can use the IDC to say, well, we think based on the respiratory variation and size that the RA pressure must be so-and-so, and then you subtract that from that 4v squared pressure, and you get what the RV or PA pressure would be.
Cool. So this is why when you see your echo report, if it says like incomplete TR jet, unable to estimate, it's exactly what Eric said, is you can't run your equations if you don't have any sort of jet. So that's when you're unable to estimate your RVSP. So this person, this woman's echo comes back, and her final read is right here. She has a LV cavity, had some mild dysfunction. She has grade 2 diastolic dysfunction, which we're not going to get into. But then she ends up having moderate to severe PH with an RVSP of 59. So you know this is more chronic because no one could survive with an acute RVSP of 59. They would be coding or have a massive PE. So this is a chronic pulmonary hypertension situation. So I told my team this yesterday, and I'm not sure they bought it or not, but I have a specific way I remember the classes of pulmonary hypertension, because I think this is something that's easy to forget. So the WHO has 5 classes for pulmonary hypertension. And if you hang with me here, this is all going to make sense. So there's group 1, there's group 2, there's group 3, there's group 4, and then there's group 5. So does anyone know what group 1 pulmonary hypertension is? Tom, say it again. Yeah, it's idiopathic. And so the medical term for that is PAH. So if you turn the 1 into part of your A, it's PAH. So it's idiopathic and pulmonary arterial hypertension. This is also what HIV is included in. Group 2, what are we working with? Say it again. The whole room came together and said it. Yeah, cardiogenic. So left side. So if you reflect the 2, what does that look like? Kind of looks like a heart. And so this is going to be cardiac causes, specifically the LV. Group 3 is where it starts to stretch here. But if you reflect the 3, it's maybe more like the lungs. And so this is going to be chronic pulmonary causes. So COPD, hypoxemia, things like that. Group 4, this is where it really goes off the rails. But if anyone saw the Fantastic Four movie that was awful from a few years ago, they used 4 to spell an A. And so this right here is going to be CTEPH with the 4 as your P. So chronic thromboembolic pulmonary hypertension. And then group 5, anyone know? Yeah, so it's everything else including sarcoidosis. So the 5 is your S. And so this is the way I've remembered it since med school. And it's I think it's paid off, but I'm not really sure. And so based on this woman's history, she has sarcoidosis, she has grade 2 diastolic dysfunction, she's on chronic oxygen. What groups does she fall into? Great, so she's got 2, she's got 5, maybe she has 3, depending on how you're classifying her, but she has multifactorial pulmonary hypertension. And the treatment is the same as our last gentleman, which is diuresis and sort of better volume control. But she does not need the goal-directed therapy for heart failure because she does not have heart failure with reduced ejection fraction. Any questions about this lady with pulmonary hypertension or our gentleman who had new onset non-ischemic cardiomyopathy? All right, well, thank you guys. Hopefully that was helpful. If you have any questions, let us know and have a good day otherwise.